This is Dr. Jerry Hesch. I'm an orthopedic manual physical therapist. I treat the person and I treat the body, and I treat micromotion and certainly treat the nervous system as well. I typically treat clients with chronic pain for 1 to 3 visits, and my goal is to be very efficient in what I do. And the methods that I use for manual therapy, I use a very small force, but I sustain it for a long time. When I do a correction of hypomobility in this region of the body, I take a minimum of 2 minutes. I'm focusing on what they call sacral torsion. Now, I wrote a chapter in 2011, a chapter in a book on that, in Eric Dalton's Dynamic Body book. Of course, today it would be a different chapter, all right? No one knows if the sacrum really twists and gets stuck within the sacroiliac joint because it has not been objectively validated. And looking on the outside of landmarks doesn't really tell us about what's going in on the inside. Stated otherwise, it's possible that the whole pelvis could twist somewhat. There could be increase in muscle tone on the lower multifidi, blocking spring mobility and giving the appearance of torsion when that might not be what's happening. So it's an unknown. But anyway, the most common pattern is called left on left rotation on a left oblique axis, but those terminologies can be confusing. The terminology I suggest is very simple, and it also communicates the treatment that needs to happen. I have only once seen a torsion present itself when the client is in extension. And I'm talking about prone passive extension, propping up on their elbows. I will sometimes see it with the client prone, neutral, and sometimes I will see it in sitting if they're just simply sitting on my treatment table and I'm palpating and motion testing. Other times they have to bend forward a little bit further. In my earlier works, I showed testing it in child pose position, and then I came to realize that the hip was at end range in child pose position, and if the person had a developmental asymmetry side to side in hip or pelvis, then that would give a false positive for torsion. I took those populations, had them sit, had them bend forward moderately, and there was no torsion, okay? So most of the time you'll find it enhances inflection, but sometimes it's still present when client is lying prone, just as is my model here, all right? So I'm gonna flip this around just a little bit. We'll keep the camera as it is. And I actually start looking at it in sitting, okay? You wanna come behind me? So it's easy to get a sense of where the sacrum is just visually, okay? It's easy to gain an appreciation where the tailbone is. And so if you come on both sides of the tailbone and just push upward, leaving about 1.5 inches space because the first coccygeal segment has little transverse processes. So we don't want to come under the transverse processes. In this case, I have 1 inch space between. We want to come out and then push up through the soft tissues, landing on the ILA of the sacrum, okay? Sometimes the curvature of the tailbone is such that it's really easy to accomplish that, all right? So in sitting, I will palpate and note that the left side is inferior in this pattern that I am about to describe, okay? But I place my thumb underneath the sacrum and I literally lift up with my thumb, okay? And if motion is present on the right, I move on and I test the left, and it correlates beautifully. If the left ILA is lower, it will not spring with the vertical force. And you could use your hand. I'll show you how I use my hand in prone, all right? Then I place my thumbs on both sides of the lower sacrum, all right? We have very good research showing that palpation as taught by myself has a good intratester reliability. That was a master's thesis by Luann Olson in Chicago. All right, so I'm on the lower quadrant of each side and I just thrust it forward. And it's a small force, But if there is mobility, you'll feel a spring forward and a recoil. And then I do it on the left and motion is blocked. So I'm describing a pattern in which the left side is prominent, posterior and lower, and motion is blocked. You can even use your fist to do the spring testing on each quadrant. Okay, very distinct. It's like pushing on a brick wall. That is how the body behaves. I've studied it for 42 years. Started spring testing in 1981 when I read that the sacroiliac joint is a shock absorber. So I tested it the same way I tested my shock absorber on my vehicle. Okay, so in this example, with the left lower quadrant being posterior, I name this pattern in which motion is blocked on the left lower quadrant, but nowhere else on the sacrum. I name it left lower sacral quadrant, prominent, meaning posterior, and stuck. Okay? I don't have to mention the fact that it appears to be side bent, and that could be a whole pelvic phenomenon again. We're not blaming the sacroiliac joint. We're admitting we don't know. What we do know is people are significantly helped by this. Not everybody, but I have a great video on a doctor who couldn't sit at the Christmas dinner, couldn't sit at Thanksgiving, couldn't travel, couldn't ski, yada, yada. His pain was chronic for over a year, and he had a torsion. We corrected it. Bingo, his life is good. So it has some utility. Do we need research? Yeah, we do. All right. So we don't have to name it by the way that it's side bent, because when you restore the anterior glide at the left lower quadrant, that's your contact point. When you restore the spring mobility, the side bending, and you come back and test side bending, it'll be symmetrical, and you do a lift test with the thumb, mobility will be present. All right? I also double check it in prone because I like to treat it in prone. It's easier. In sitting, you have all this upper body weight, right? All right. So in, well, we'll pretend the client's laying here, and we'll pretend I'm on the side. And I test under the ILAs. And in prone, if this one is still lower, I go ahead and use the outside of my hand, and I load it, and I spring it. Okay? And then I also test this quadrant, spring it down towards the, straight down to the floor. Okay, straight anteriorly. I test this one moves, I test up here, I test up here. Each of these three quadrants moves. All right? Now you will find a little bit of blocked joint play in the L5S1 facet with this pattern, but the facet tends to correct when we correct movement. So now I'm going to demonstrate to you the corkscrew technique that I really like. So if you would kindly come around the other side. So we stack vectors relative to the resistance. So number one, the sacrum behaves as though it's side bent. The motion is blocked when we try to go vertically, spring it towards his head. So I add a superior vector on the sacrum, on the ILA of the sacrum, with about 15 pounds of force. I practiced many, many times. It's easy to learn that, and there's good data on that therapists can learn to apply. Repeat forces 2 weeks later. Matthias Bach, B-A-C-H. I'm forgetting the main author, sorry. But anyway, then I add another vector, which is now pushing straight anteriorly. So we go up, forward, and I come on the other side, and I just add a corkscrew maneuver. So I just tighten up everything, and then I hold that force. And it is about 15 pounds on each side, and I maintain that for 2 minutes, and it works beautifully. Okay? It's typically once and done. I then teach them, I have them come back the next day or so, and I check everything, and typically it's moving beautifully. And then I teach them self-correction or prevention, and I have a separate video for that. This video is getting pretty long, so I'm going to stop here. Just go to the other video, type Hesch Sacral Torsion Self-Treatment if you're interested. And we have online courses. We do a little bit of a traveling to teach. We treat patients here over the course of 3 days who travel from around the world with chronic pain, and we help a great majority of them. Thank you.